All right, folks, last blood lecture is right here. So this is about blood clotting, hemostasis, and platelets, the last formed element to talk about in this chapter. So platelets are called thrombocytes, and it's a little misnomer because the suffix "cyte" means cell, and platelets aren't complete cells. They're cell fragments. But they are enough of a cell fragment to have uh, normal normal cell metabolism. They only live about 10 days, however. So we're constantly making the platelets and they're constantly being consumed. Even when you don't have any apparent bleeding, platelets are someplace in your body patching up damage to a blood vessel, and that's platelet consumption. So we're constantly making them from megakaryocytes. That's the precursor of platelets. It's called a megakaryocyte. Megakaryocytes don't ever typically leave the bone marrow. And platelets are blebs or little pieces pinched off the megakaryocyte. If your platelet count is too low, you have thrombocytopenia. If your platelet count is too high, you have thrombocytosis. And the platelet count runs anywhere from, say, 150,000 to 450,000 per microliter. Now, let me just remind you, a normal white blood count was 5,000 per microliter. And by the way, a normal red blood count was, say, 5 million per microliter. So you can see the difference here of the whites, the platelets, and the reds. Red blood cells are about 1,000 times more than white blood cells because white blood cells run. I'm not giving you ranges like I should be here. So white blood cells run anywhere from, say, 4 to 12,000 per microliter, and red blood cell counts run. They have a range as well, but they're about 5 million per microliter. And then platelets are about 150,000 to 450,000 per microliter. All right, so that's the normal. What do platelets do? First of all, they release chemicals that one of the chemicals attracts more platelets. So there's a little positive feedback loop going on to make a platelet plug. They are involved in blood clotting. They make a platelet plug that clogs up a break in the vessel wall so you don't hemorrhage. And they're involved in hemostasis and other ways that we're about to talk about. All right, so let's get going with talking about platelets and blood clotting. There's three phases to hemostasis. Actually, there's four phases if you want to count the clot retraction. And these phases go as follows. When you break a blood vessel, you have the vascular phase. This is the blood vessel spasms shut. Spasms, well, it doesn't completely shut. So maybe not completely shut, but spasms narrower. Because, if your blood vessel spasmed completely shut, you wouldn't bleed at all. You wouldn't even need platelets or fibrin. Your blood vessel would spasm closed and no blood would go to the break until it was healed. So by narrowing your blood vessel by this spasm, you reduce the amount of hemorrhage, but you really have to patch up that hole in your blood vessel or you will hemorrhage. And then we have the platelet phase, and this gives you the platelet plug, but it's weak. The platelet plug is weak, and we need to strengthen it, that's the coagulation phase. And the coagulation phase is fibrinogen becoming fibrin. But that's a big story because it's not a simple reaction of fibrinogen becoming fibrin. And fibrin creates a mesh around the platelets. And that makes the platelets strong. The platelet plug becomes strong. Now, this story of fibrinogen becoming fibrin is called the clotting cascade. And every time there's a biological cascade, the power in that cascade is amplification. And I'll show you that when we get to it. And then lastly, after you have this fibrin mesh around the platelets, the clot retracts. And if you ever had a scab that after a day or two pulled your skin real tight. That's why your clot retracted, and it pulled the skin real tight, and that scab was, that's what it was doing. That's clot retraction. All right, so those are the phases of hemostasis. This is telling you some parts of the vascular phase. First of all, the endothelial cells, the epithelial cells lining your blood vessels, are called endothelium. They release some chemicals that attract platelets, like and activate platelets, by the way. So attract and activate. So they release ADP. They release tissue factor. Tissue factor actually activates the coagulation phase. So even while you're activating platelets, you're activating some of the proteins necessary in the coagulation phase. You stimulate smooth muscles, and that's part of the spasm. That's the spasm right there. You release some other chemicals called endothelins. And what these do is they actually do a couple things. First of all, they start the clotting process. And then they also start a process simultaneously which dissolves the clot. And I know that sounds funny. Like, why would you start a clotting process and then also start a process that dissolves the clot? Well, you don't want that clot there forever. And, as a matter of fact, you don't want it there very long. And you don't want other places in your body to clot. You want the clot to stay local. So it's really a balancing act between generating a clot that stops you from bleeding and making sure you don't clot elsewhere in your body or even clot too long where you're bleeding. Because clots can be bad. They're called embolisms or thrombotic embolisms, and they can lead to heart attacks and strokes. So you really do want to control clotting, even in the midst of generating a clot. All right, so this is part of the vascular phase right here. And then you have the platelet phase. And the platelet phase is a positive feedback loop. And what that means is, I'm looking right here, I'm looking down here. As these platelets come in and seal up the hole in your blood vessel, they release chemicals that attract more platelets, which release chemicals that attract more platelets, which bind and release chemicals that attract more platelets. Now you're going to say, well, when does it stop, this positive feedback? It stops when you have a coat of platelets and the collagen, this underlying collagen right here. This is all collagen in the basement membrane. This underlying collagen, and it's actually collagen in the tunica media, and you'll learn that in lab. There's layers to these blood vessels. The underlying collagen, when it's covered up, and we have a coat of platelets here, that stops the positive feedback loop. So we have a platelet plug. Now that platelet plug is weak. Just think of this. When you cut yourself shaving and you have to go to work and you don't have time to sit there and hold it, you put a piece of toilet paper on it. And why do you do that? Because the vascular phase takes about 30 minutes. Yep, right here. The vascular phase, the spasm and release of chemicals, that takes about 30 minutes. And then the platelet plug that results at the end of this vascular phase and within this platelet phase is weak. And you know it's weak because if you pull off that toilet paper that you put on your cut too soon, you start bleeding again. What you've really done with that toilet paper that you put on your cut is you've actually used toilet paper in place of platelets. But the platelets do bind loosely. And then you pull the toilet paper off too early and you start bleeding again because you pulled the platelets out. They're very weak. But if you wait long enough until the fibrin meshwork is around these platelets and then you pull the toilet paper off, you won't bleed because that fibrin meshwork around the platelets is very strong. So these are some of the chemicals that platelets release. They release adenosine diphosphate, ADP, that activates platelets and calls more platelets to the area. You release thromboxane. Now this is where aspirin acts. So aspirin acts right here. What happens is you have some precursors going to thromboxane synthesis. And aspirin, there's several enzymes in here, and one of the enzymes is, instead of calling it enzyme 1, let me just tell you what it's called. It's called cyclooxygenase, and we abbreviate that COX-1, cyclooxygenase. Aspirin, acetylsalicylic acid. That's aspirin, ASA, acetylsalicylic acid. Inhibits COX-1, so you can't make thromboxane. So if you can't make thromboxane, then you can't have the platelet aggregation and activation. So you're inhibiting platelet clumping. And you also activate clotting factors. Tissue factors are released, that activates clotting factors. Platelets release some other things that activate clotting factors, and we'll learn some of these. Calcium is also necessary for clotting, and I'll show you where when we do the clotting cascade. Now, while you're activating platelets, you are also inhibiting clotting. And you're doing this simultaneously, but the inhibition is slightly delayed. So yes, you do clot, and you do stop hemorrhaging. And then right behind that, you're inhibiting clotting and inhibiting further platelet aggregation and coagulation because you don't want unwanted clotting. One of the major players here is prostacyclin that inhibits platelet aggregation. So yeah, you had a positive feedback loop that allowed for platelet aggregation and you sealed up the hole in your blood vessel, and then right behind that you're inhibiting more platelet aggregation. That way you don't have unwanted clots floating around. Other inhibitory compounds are released as well. We probably won't talk about many of them. Okay, so that's the platelet phase. And then we have this very complex clotting cascade. It's called the coagulation phase. And there's two pathways. There's an extrinsic pathway right here, and the extrinsic pathway is 7, and well, it's tissue factor and 7, and that goes to the common pathway. And then there's an extrinsic pathway right here, which is 12, 11, and 9. So it's 12, 11, and 9. Roman numerals, we use Roman numerals to designate these clotting factors. And they feed into the common pathway. And then the common pathway is 10, 2, and 1. And there's a couple other things here. I guess I should say that 8 is part of intrinsic. And also with 10, 2, and 1 in the common pathway is a factor 5. And I'll show you some more details in a second. 2 is prothrombin. Prothrombin is 2. And what is thrombin? 2 active, which we say 2A. 1 is fibrin. And fibrin's 1A. 1 is fibrinogen, and 1A is fibrin. So prothrombin is activated to thrombin, which activates fibrinogen to fibrin. Fibrin is active. Okay, so I don't need you to memorize every swinging coagulation protein, but I do need you to know that prothrombin and thrombin is 2 and 2A, and fibrinogen and fibrin is 1 and 1A. Notice that we need calcium in both extrinsic and intrinsic pathways. If you remove calcium, you can't clot. And in fact, this is the strategy we use in some blood drawing tubes. We chelate calcium and don't allow the blood to clot. Because some of those vacutainers that we use to draw your blood, we don't want the blood to clot. And of course, sometimes we want the blood to clot. So when we don't want the blood to clot, one of the strategies we use is chelate or sequester the calcium, and your blood doesn't clot. This is not from your book, obviously, but this is the intrinsic pathway. Notice that 12 is activated to 12A, which in turn activates 11 to 11A, which in turn activates 9 to 9A, which in turn, with the help of active 8A, which is the hemophilic factor, because if you lack factor 8, you have hemophilia, and that's actually called hemophilia A. There's 3 types of hemophilia. 8, along with 9, and actually this is called the 10-ACE complex. 8, 9, 10, calcium, and phospholipid is called the 10-ACE complex, and it activates 10 to 10A. Now 10A, 5A, phospholipid and calcium is called the prothrombinase complex, and that activates prothrombin to thrombin. And then thrombin activates fibrinogen to fibrin, and then fibrin cross-links your platelets. Okay, so that's the intrinsic pathway. Now there's an extrinsic pathway here, which is not as complex. By the way, the intrinsic pathway, this is the common pathway. 10 down. 10 down is the common pathway. So really the intrinsic pathway is only to here, and then it joins the common. The extrinsic pathway is really tissue factor and 7. So it's saying trauma here, but trauma leads to tissue factor exposure. Actually, it says it right here. You can see trauma leads to tissue factor exposure. Tissue factor activates 7 to 7A. 7A activates 10 to 10A. And now you're in the common pathway. This is a cascade. The power of this cascade is amplification. And what that means is it doesn't take much of 12 or of 7 to give you a lot of fibrin, because you amplify every step. Let me see. These coagulation proteins exist as proenzymes. So 12, 11, 9, 10, 2, 1, 7, 5, 8, they all exist as proenzymes. And they're going to be activated into enzymes, because we don't want these coagulation factors floating around our blood in the active form, because we don't want little blood clots floating around and clogging up our arteries and our arterioles. So these float around as proenzymes and then are activated when you have blood vessel damage. Okay, so that's before I go on, notice these red dotted lines. These are all inhibitory. So just like with the platelets, that as soon as I started sequestering and aggregating and activating platelets, I also started inhibiting their aggregation and activation. See, because I want to control clotting just as much as I want to clot. Just like we did that for platelets, we also start inhibiting this cascade just as soon as it starts. Now, the inhibition lags behind, so you make a significant amount of fibrin clot. But just lagging behind that is the inhibition of this cascade, so it doesn't go crazy and lead to a whole bunch of clots floating around your blood. So there is inhibition right behind this. This is a table of all of the factors and what their names are. I need you to know that factors 1 and 2 are fibrinogen and prothrombin. So 1 active is fibrin, 2 active is thrombin. I need you to know that. I need you to know that 2, 7, 9, and 10 are vitamin K dependent. 2 is vitamin K dependent. 7 is vitamin K dependent. 9 is vitamin K dependent. 10 is vitamin K dependent. 2, 7, 9, and 10. 2, 7, 9, and 10. Because there's a drug we take that acts on those factors, and it's called Coumadin or warfarin. It's a vitamin K analog. It inhibits those 4 factors. Okay. 2, 7, 9, and 10, vitamin K. All right. So other than memorizing 1 and 2 and their names, fibrinogen and prothrombin, and 2, 7, 9, and 10 being vitamin K dependent, I wouldn't commit the rest of these to memory. This is another picture from another book. This is a pretty cool picture. Now look at, be careful. In this picture, the intrinsic was on your left and the extrinsic was on your right. And whoops, in this picture, the extrinsic's on your left and the intrinsic's on your right. The intrinsic is 12, 11, 9. 12, 11, 9, 8 too. I don't forget 8, but 8 is part of the 10-ACE complex, and I always just put it there. 12, 11, 9, 8 is intrinsic. Tissue factor in 7 is extrinsic. And the common is 10-2-1. That's the common, 10-2-1. And 5. You better put 5 in there. Why do I... 8 and 5 are a little... They're actually not enzymes, just so you know. They're not enzymes like the rest of these. They are cofactors. They're very important cofactors, but they're not enzymes. And 8 belongs to the tenase complex, and 5 belongs to the prothrombinase complex. So this prothrombinase complex right here, number 4, this prothrombinase complex is really 10A, that's 10 active, 5A, calcium, and phospholipid. That's what it is. That's the prothrombinase complex. The 10-ACE complex, we call it 10-ACE because it's activating factor 10, is right here. But I'm going to add something else to it. That's the 10-ACE complex. It's 11, factor 8, calcium, and phospholipid. That's the 10-ACE complex. All right, so I like this picture now that I'm looking at it. This picture is far better than the one in your book. Except for the one in your book does do one thing for us. It shows us that this cascade event is occurring on the platelets, co-located with the platelets. In fact, these blue strands are the fibrin strands. They're cross-linking the platelets and making them strong. All right. This is showing you vitamin K and Coumadin. The reason why Coumadin is an anticoagulant is because it looks like vitamin K. See how different Coumadin, Coumarol, warfarin look like vitamin K? Well, because they look like vitamin K, they can replace vitamin K in this biochemical pathway. What vitamin K does is it allows this enzyme gamma carboxyglutamic carboxylase. Just call it carboxylase. Just call it carboxylase. Vitamin K allows this carboxylase to work. You can see that I need vitamin K right here. And I need vitamin K to allow this carboxylase to work. If this carboxylase doesn't work, then 2, 7, 9, and 10 don't work. All right? Well, as it turns out, when you do this reaction one time, your vitamin K has changed. And you need to recycle it back to reduced vitamin K. Coumadin stops that. Coumadin stops that vitamin K epoxide reductase enzyme. So then I can't run this carboxylase because all my vitamin K is trapped as oxidized vitamin K. So that's what happens. This is another picture showing you the same thing. So Coumadin is an anticoagulant because it stops vitamin K from working. Another picture showing you the same thing. Okay, let's talk about some anticoagulants. Well, antithrombin 3, now it's just called antithrombin. We don't say 3 anymore, we just call it antithrombin. I'm not sure why they changed it. Antithrombin is a strong anticoagulant, and it doesn't only act on thrombin. It acts on every single factor in here. Every single one. 12, 11, 9, 10, 2, 1, 7, 5, 8. It acts on all of them. So antithrombin is a pretty powerful anticoagulant. There's another one called alpha-2 macroglobulin. There's some other ones, by the way. I'm not going to go through all of them. Heparin enhances antithrombin. It enhances it greatly. So much so that heparin's a pretty decent anticoagulant. Aspirin stops the formation of thromboxane. So if we don't have thromboxane, then we don't activate and aggregate platelets. Protein C and protein S are anticoagulants. And let me show you how they work. Even in the midst of making thrombin, which is a procoagulant, even in the midst of making thrombin, thrombin actually starts the anticoagulant pathway. Thrombin binds a thrombomodulin sticking off your endothelial cell membrane. And the thrombomodulin thrombin complex activates protein C. By the way, protein C is vitamin K dependent as well. APC stands for activated protein C. Well, activated protein C doesn't act alone. It binds protein S. And this protein C, protein S complex inactivates 5 and 8. So it takes 5 and it inactivates it, and it takes 8 and it inactivates it. That's why I have 5I and 8I. They're inactivated. Now, if protein S, protein C complex inactivates 5 and 8, look what we're doing. We just knocked out 8, 10-ACE goes away. We just knocked out 5, prothrombinase goes away. If the 10-ACE complex goes away and the prothrombinase complex goes away, I don't make fibrin. So this is how protein S and protein C work. That they inactivate 5 and 8. Now here's the catch. Protein S, very little, only 40% of it floats around free. And you can see that right here, 40% floats around free. The rest is bound to this complement 4B binding protein. C stands for complement. We're going to talk about complement later, but C stands for complement. The complement 4B binding protein binds protein S, and it binds the majority of it. The free protein S that's floating around free is available to make a protein C, protein S complex. Now, what happens is when you're infected with, even if you have a bacterial infection, your C4B increases. If you increase your C4B, then your C4B binding protein increases as well. Then you increase your C4B and C4B binding protein complex, and that chelates or sequesters more protein S. So I have less free protein S floating around, able to make an activated protein C, protein S complex. So I don't inactivate 5 and 8A as much. So this very infection that made complement increase can lead to aseptic DIC. So septic means a bacterial infection. And by the way, it's usually a gram-negative septic, DIC, disseminated intravascular coagulation. And the reason for that is because you don't inactivate 5 and 8. So 5 and 8 stay active. You have these little clots now. And these little clots are floating around your bloodstream. This can be a deadly disease. DIC can be deadly. We must treat DIC. So that's how gram-negative sepsis, gram-negative bacteria in your blood, can lead to DIC. Now, after we make a clot, we want to digest it. I mean, the clot, you want to stop hemorrhaging, but you don't want that clot there forever. So we digest the clot, and that's called fibrinolysis. Here's how we have fibrinolysis. Plasmin is fibrinolytic. But plasmin doesn't float around in the active form. It floats around in a precursor form called plasminogen. So how do we convert plasminogen to plasmin? And the answer is TPA. TPA is the best one to talk about here. TPA stands for tissue plasminogen activator. There's a couple other things that will activate plasminogen as well. Tissue plasminogen activator. And then plasmin digests fibrin clot. This is so powerful that one of the things we give to heart attack, myocardial infarction patients is TPA. But here's the deal. You give TPA to a patient in the hospital and now you can't draw their blood peripherally because you can't afford to puncture their skin and puncture their blood vessel because this stuff won't allow you to clot. Even if you try to clot, this will digest it. And by the way, the plasmin will digest some of those coagulation factors as well, so you won't be clotting. So yes, TPA is given in the hospital as a treatment, but it's given under strict scrutiny and care of the patient, where we don't have invasive procedures into their veins any longer. What they do is they usually sew in a central line or an indwelling catheter that's sewn right into one of their blood vessels, and then you just draw blood off of that as you need it. So you're not sticking needles into their blood vessels anymore, because you won't ever get them to stop clotting while the TPA is high in their bloodstream. But they won't have a heart attack from another clot if you give TPA, because you're going to digest all kinds of clots. That's it, folks. See you in the heart chapter.